today I am planning to take bony tumors, and again this is a very important section, and there is no exam which does not include at least one question from this segment. So definitely you will be having uh, at least one question from this segment, right? So this is an extremely important segment. Now the very first thing which you should know is about the location of the tumors in respect to the different areas of a long bone, right? So we know that in a long bone there are 3 to 4 areas depending on the age. If it is a adult, you will have diaphysis, or what is known as the shaft. Then the expanded portion is all metaphysis. Okay, so this expanded portion is all metaphysis. Then there is one growth plate which is known as epiphyseal plate. Shanwaz bhai, good evening. I'm good. Okay, so this is growth plate which is also known as physis, and the last area is epiphysis. Clear? So this one is epiphysis. Now needless to say, this is present only in children's and not in adults. Clear? These three parts are in adults only, right? So we have to discuss the tumors, the location of the tumors with respect to these areas in a long bone. So there are many conditions which can arise from different parts of the bone, but there are some extremely important entities which you should know properly, right? Like if I say epiphyseal, you should remember at least one condition, and that is giant cell tumor. Clear? So at least one condition from epiphyseal, this is giant cell tumor. If I say at least one condition from metaphysis, you have to answer osteosarcoma. And if I say one condition from diaphysis, then you have to remember Ewing's sarcoma. Clear? So these are just one condition from different areas of the bone. Now there are some other conditions, and if you can remember them, nothing better than that. Okay, if you can remember them, nothing better than that. So suppose from epiphyseal, from especially from metaphyseal, you can remember one more condition, that is if you remember from infective, this is not tumor actually, so that is osteomyelitis. We already discussed about that. So this is not a tumor actually, this is just one condition which is related to metaphysis, right? Apart from this, the tumors which you can remember here, one is osteochondroma, and the other conditions which you can remember here are especially bony cyst. So again you can remember bone cyst. So it can be simple bone cyst, and it can be aneurysmal bone cyst. We will discuss these conditions later on, right? So osteomyelitis I have already told you, and then yes, fibrous dysplasia, if you can remember, but not that important. Okay, and one is non-ossifying fibroma, if you can remember, although not that important. We will discuss this condition also today. So non-ossifying fibroma. Clear? So you can see there are plenty of conditions which are coming, which are originating from metaphysis. Of course, osteosarcoma is the most important and which everyone should know. So osteosarcoma. Then continuing with the tumors, osteochondroma, which is also known as exostosis. Clear? Then bony cyst, it can be simple or aneurysmal. Then two less important conditions, one is fibrous dysplasia and second is non-ossifying fibroma. So these are all metaphyseal. From diphysis, we have already taken one Ewing sarcoma. The another one which you can remember is osteoid osteoma. So this is one important condition which we will discuss here, right? So, and third is fibrous dysplasia also, it can be seen here, right? So anyway, these are some important conditions which you can which you should remember in terms of the location from bone. Okay, so and one point you can just note out that majority of the conditions are in metaphysis. So if there is a question about the location of a tumor in bone and if you don't know the answer, then I think you would understand my point that please go for metaphysis. If you don't know the answer and if you mark metaphysis, the chances of answer being correct are pretty more as compared to epiphysis or diaphysis, right? So we will take the entities one by one and we will start with the benign entities first. And the very first condition is osteoid osteoma. Now for osteoid osteoma, we say that it is the most common primary benign tumor of bone. I think most of you must be understanding what is the meaning of benign or malignant. Malignant means very aggressive and benign means not that aggressive. And when I use the word primary, it means it is originating from bone. Clear? So the tumor cells, they are originating from bone itself, so therefore we will call it primary. The word secondary means that the bones are involved. Secondarily, the origin or the primary source of tumor is somewhere else, so that is secondary, like metastasis. So that is secondary, right? So whenever we use the word primary, it means we are discussing the tissue from which the cancerous cells have originated, right? So this is commonest primary benign tumor of bone. Now suppose if I remove the word primary from here and if I simply say commonest benign tumor of bone, so here the answer will change to osteochondroma, right? So you see the answer will change to osteochondroma. And if you know the meaning of the word chondro means actually cartilage. So it means the tumor is having some bony component and some cartilaginous component, although we will come to this entity later on. So right now we will focus more on osteoid osteoma, which is the most commonest primary benign tumor of bone. Now the classical feature or the classical radiological feature of osteoid osteoma is a nidus, right? So nidus is the classical radiological feature of the osteoid osteoma, and it has got some like if I draw nidus here, suppose if the nidus is something like this, okay? So there is a black cavity and it has got some white shadows in between, right? So this is all something like this, right? So this is nidus, and within that nidus you will see small white osteoid trabeculae. So these are osteoid trabeculae, right? So the characteristic feature is a nidus, and in this we have tangled arrays, something like this, tangled arrays of partially mineralized osteoid trabeculae, and surrounding this is all white dense white bone, although I'm drawing it with red, but this is all dense white, right? So this is sclerotic bone, and whenever you find the word sclerotic, it means white. So if we take it in a X-ray, so this is a classical X-ray of osteoid osteoma, and what you can see here, see, this is the cortex, fine. This is the cortex, the white area, this is all cortex, and in between this is all medulla, or what we call medullary cavity. Now if we see properly, the tumor is arising from the cortex, okay? So the tumor is arising from the cortex, and therefore we say that this is a cortical lesion. It is not involving the medullary cavity or the entire bone. It is just arising from one of the cortex, and in the cortex we will see a black small cavity, and this is known as nidus. And in this black cavity we can see small white lines. These are actually osteoid trabeculae. So, and surrounding this we can see all whiteness. This whiteness is known as sclerosis, right? So on radiology it is quite easy to identify. In fact, it is the most easiest to identify the osteoid osteoma, because the very first thing which you will see here, that it is involving only one cortex, right? So it is involving only one cortex. See, the other side cortex is absolutely normal, so it is uninvolved. And this kind of presentation you will not find in any other condition. So this is osteoid osteoma, a cortical lesion, right? So we will see a cortical nidus. So very easy to identify on X-ray. Now this is AP view. Suppose if we are taking a transverse section or a transverse view, so normally when we see the bone, it is something like this, okay? So this is all cortex, okay? So this area is all cortex, and in the center we have the medulla. So this is the medulla or medullary cavity. So I will write medullary cavity so that you don't think of medulla of brainstem. So this is medullary cavity. Clear? So this is transverse section. Now what happens in osteoid osteoma, as I told you that it is a cortical lesion. So suppose if this is the bone, right? There will be a nidus, something like this. So this is the nidus here. Clear? So I think you can all clearly see that the nidus is developing within the cortex and the medullary cavity is uninvolved. So this is a cortical nidus, and in transverse section it is very easy to identify. And then you can see tangled array of partially mineralized osteoid trabeculae, and there is all dense white here, and that is known as sclerosis. This is sclerosis. Clear? So very easy to identify, especially on transverse plane, because you can see the lesion is within the cortex, right? So this is how you need to identify osteoid osteoma on X-ray. And if it is a purely image based lesion, this is how you have to focus on X-ray. But if it is given along with clinical case history, then the answer is 100% easy to make, because there is a characteristic history. The patient will come with a pain sensation, and this pain sensation is more at night. So the patient will come to you that I am having pain in the leg region, and that is extremely worse at night when I sleep. And if I take aspirin, the pain goes away. So just knowing this fact that the aspirin is relieving the pain of the tumor, we call this condition as aspirin tumor. Clear? So this is the nomenclature here. So if you find anything like this with a classical x-ray, straight away you can go to osteoid osteoma, right? So on x-ray we have already discussed that outer side there will be a zone of sclerosis, and sclerosis is what? It is whiteness, all white, and there is a radiolucent nidus. Now lucent means black, okay, on x-ray. So if I say radiolucent, it means the tissue will appear black on x-ray. And the size is very important here. It is less than 1 centimeter. Some book says less than 2 centimeter, but it doesn't make any sense. So less than 1 centimeter is also good. And diagnosis, yes, you can do x-ray, you can do biopsy. So right, so x-ray help us in making a diagnosis, and for any tumor biopsy should be done. Prognosis is extremely good because we can remove the tumor, and since it is a benign tumor, so it's very easy to correlate that the prognosis will be good. And it is not a pre-malignant condition, so there is no fear that later on it might get converted into a malignant tumor. So it is not a pre-malignant condition, so prognosis is extremely good. So this is in short about osteoid osteoma, and if there is a question, it will be definitely framed from this much stuff only. Then moving forward to osteoblastoma. So this is osteoblastoma, and this entity is also in radiological appearance, it is similar to osteoid osteoma. And when I say similar to osteoid osteoma, it means it will also show a nidus, right? It will show a nidus, clear? And I think most of you must have understood what is a nidus. So there is a black cavity, and in that black cavity we can have multiple white lines like this, and this is surrounded by a zone of sclerosis or whiteness. Okay, I'm sorry, I'm using some other colors, but it's just for demonstration purpose, right? So this is a classical nidus. So here nidus is there, but the size of nidus is more than 2 centimeters. So this is how it differs from osteoid osteoma, where the size of nidus is less than 2 centimeter, or you can say less than 1 centimeter. And second thing, this is one point, and second thing is the location. Here we see that the osteoid osteoma is commonly found in lower limbs, especially in tibia. This is especially in tibia, okay, although this is femur. And osteoblastoma, as you can see here, it is involving the vertebra. It is involving the vertebra. So there are two classical differences. One is in terms of size and another is in terms of location. And I think it's very easy to identify vertebra. This is vertebral body, clear? This is the canal for spinal cord. Then these are all transverse process, and in the transverse process you can see a black cavity, okay? So this is a black cavity like this, and then in this black cavity you can see multiple white shadows, right? So this is a classical nidus in transverse process. So this is osteoblastoma. Then we move forward to another term, and this is chondroblastoma. Now remember one thing, when we talk about the word osteo means bone, clear? And when we use the word chondro word is cartilage. So these terms actually help us in understanding what uh, tissue we are going to find in that tumor. So chondroblastoma is also known as Codman's tumor. Now I have kept this entity willingly just to highlight this particular word, Codman's, because from a student's perspective, many times they find the word Codman's, they simply jump onto osteosarcoma because they think that the condition discussed it's Codman's triangle, right? So this is not Codman's triangle, this is Codman's tumor, which is another name for chondroblastoma. So just to highlight this difference, I have kept this entity. Otherwise it is not that important, and I don't know if any question has been asked on this particular entity till date. So just to differentiate this Codman word, right? So anyway, if I kept, let me have few words for this. So chondroblastoma, you can see a well circumscribed lesion. Now when I say well circumscribed, I mean the tumor is well localized. Circumscribed means it is well localized, and you can clearly mark the extent. So we can clearly mark the extent of the tumor. So this is right. So this is well circumscribed or properly localized. Now if you look at the X-ray, again you can see here the tumor is somewhere here. Now this faintly white line is actually the growth plate. Clear? So if you see this faint white line, this is growth plate, or what you call physis, and here white means it has already fused. So this person is the subject is must be over 18 years of age. So the growth plate has fused. Okay, so and this area is what? Epiphysis. So the tumor is occurring from epiphysis, right? Similarly, you can see the physial or growth plate of the lower end of femur also. So anyway, this tumor is located from which located in which area? This is epiphysis, and sometimes it might show calcification. Again, not an important feature, right? So chondroblastoma, Codman's tumor, epiphyseal. Just remember these three words. Okay. Then we move on to giant cell tumor, and this is the most favorite for exam setters, and the age group is adult, 20 to 40 years, and we already discussed like it originates from the epiphysis, right? But it has a tendency to grow, and it grows towards metaphysis. So at times you might see the radiological findings in metaphysis, but this does not mean that it is the tumor originating from metaphysis. It is actually an epiphyseal tumor which extends till metaphysis. So right, so it is just extension. It is especially in lower femur and upper tibia. Now this is the same location as like for osteosarcoma. Clear? Then for you can say osteomyelitis. So what I mean to say that if there is a question about site of tumor in the body, and if you don't know the answer, you can think of the knee joint, right? So if you don't know the answer, in that case, please mark the answer as knee joint. And if it is specifically in terms of bone, then you can write lower end of femur as the first. If it is not in the option, then you can go for upper end of tibia, which is the second for most of the entities, right? But not always. So it's just in case you don't know the answer and you have to play a guess game. Okay, chalo. So giant cell tumor. Now histology, we find two types of cell. One are mononuclear and another are multinuclear or multinucleated, right? Mono means one, multi means many. So there are two types of cells. If I draw, so this is a cell in which there is one nuclei, so this is mononuclear. Okay. On the other hand, there are some other cells which are pretty big and they have multiple nuclei. So these are the multinucleated, okay, giant cells. And in old era, it was thought that these are the tumor cells, right? So these were thought to be the tumor cells. And therefore, the name given was giant cell tumor. But later on, it was realized that these are the non-tumor cells. In fact, these are the tumor cells. So anyway, by that time the nomenclature was already done, so we are continuing with that term even today. Anyway, but the mononuclear cells are the tumor cells and not the multinucleated giant cells, based on which the nomenclature has been done erroneously, right? So anyway, now what you will see on X-ray, I think one finding is clear to all, that is soap bubble appearance. I think this is a classical term which has been taught to the students over the years. So, but apart from this, I want to show you two more findings. So if you draw a line along the long axis of the bone, you will see that the tumor is more towards one side as compared to the other side. So such an arrangement is known as eccentric. Eccentric means more towards one side. Clear? This is eccentric. And the second E is, of course, epiphyseal. I think most of you must be remembering this, that it is a epiphyseal tumor. So remember, two E's, eccentric, epiphyseal. And of course, it is extending till metaphysis from epiphysis, and you will see a classical soap bubble appearance, which I think everyone must be knowing, right? So this is a classical soap bubble appearance. Anyway, remember two E's here. Fine. Eccentric, epiphyseal for giant cell tumor. And treatment, we have to excise the tumor and do reconstruction. Like if we are removing the lower end of radius, this is of course radius here. So what we will do, we will remove this tumor and we will put a fibular graft. So this is for giant cell tumor of lower end of radius, right? So for this particular case. Then another is osteochondroma, which is also known as exostosis. And one fact we have already discussed while discussing osteoid osteoma, that it is the most common benign tumor of bone. Now I have excluded the word primary here. So it means we are not taking the condition which is originating from the bone itself. Now here you are again getting this word chondro. So it means there is some term related to cartilage. Now what happens? This tumor grows in size till there is growth at physis or growth plate. So this black line is physis. Okay, so this is physis. So whenever till the period the physis is active, usually you can take it a time period of 16 to 18 years. Till the period the physis is active and it is contributing to the longitudinal growth of bone, the tumor will increase in size. So this is one rule, right? And once the growth plate fuses, the tumor should stop growing. So rarely grows beyond the age of skeletal maturity, right? So this is one fact. But if it continues to grow, even after skeletal maturity or growth plate fusion, then we will say that now it is no more benign, it has converted into malignant entity. Clear? So this is one indication to us that now this tumor is no more benign, it has undergone malignant. So suppose if a patient is of 25 years and if this swelling is continuously increasing in size, it should alert us the possibility of malignant conversion, and the malignant counterpart of osteochondroma is chondrosarcoma. Clear? So the osteochondroma has now become chondrosarcoma, right? So this is one indication. Then, as we said that it is seen in children of young age when the growth plate is active. So patient can come to us anytime with swelling, or you can say bony mass. Now it arises from, if you see here, this is all metaphysis. So it arises from metaphysis. Originally it is related to growth plate, but since the activity of growth plate is so fast, the distance between the growth plate and the tumor keeps on increasing, right? So initially it is in close proximity to growth plate, but as the length of the limb increases, the growth plate keeps on going downward, and there is a lot of gap between the tumor and the growth plate. So it can be seen in long bones, it can be seen in flat bones of face, or small bones of hand and feet. And we are using the word chondro here, that is cartilage. So now what is the concept of this cartilage? The concept is that this tumor is covered by a cartilaginous cap, right? So this is the cartilaginous cap, and therefore we are using the word osteochondroma, right? So this yellow one is all mature bone, okay, and this mature bone is covered by a cartilaginous cap, and therefore now this cartilaginous cap is not seen on X-ray. Therefore we will perceive the tumor size as 1 centimeter, 2 centimeter, whatever. But when we operate, we will find that the actual size of the tumor is much bigger than what we have seen on X-ray. And why it is much bigger? Because of that cartilage cap, which can be seen with naked eye but not on X-ray. So X-ray impression is always smaller as compared to the actual size of the tumor, right? And yes, this cartilage can be seen better on MRI. Now this cartilage cap is also, so we can write here the cartilaginous cap. Now this cartilaginous cap is also, in one way it is prognostic for us, you can say, because normally it should be less than 2 centimeter. But if it increases in size, it again indicates that the tumor has become malignant, right? So it has become malignant. So again, there are two indicators for us to clinically check whether the condition is benign still or has undergone malignancy. So one is if it continues to grow, this is clinical fact, and second is you do MRI and look for the thickness of cartilaginous cap. If it is more than 2 centimeter, you can straight away say that yes, this condition has now become malignant, that is, there is development of chondrosarcoma, right? Otherwise, in majority of the cases, it does not undergo malignant conversion, right? So rarely it undergoes. It is very rare, of the rarest cases, when we find this malignant conversion. And the two classical things which hints or which indicates the malignant conversion are the clinical increase in size or increase in increase in the size of cartilaginous cap on MRI, right? Similar to osteochondroma, we have one more term, and this is enchondroma. Okay, so almost similar sounding, osteochondroma, enchondroma. Now for enchondroma, you have to remember only one thing: the moment you have a X-ray of hand which is showing two features, osteolytic lesion, and you can see a expensile lesion. Clear? So if you see a X-ray of hand, and if you see a osteolytic, which will appear radiolucent. I think radiolucent word is clear to all of you. Lucent means black. Okay. So if you see X-ray of hand, because bones, they should appear white, and if a bone is appearing black, it means there is damage to the bone in terms of tumors. So here you can see there is a classical X-ray, and you can see expensile. Expensile means it is expanding, and you can see bony destruction here. So this is expensile bony destructive pathology. And the moment you have X-ray of hand, even if you don't see, or even if you don't interpret anything, straight away jump to enchondroma. If you don't know the answer, there is no harm in marking enchondroma, right? So X-ray of hand, or at times feet, but majority it is always hand. So affects the small bones of hands, or sometimes very rarely we can see it in feet as well. So it arises from the remnants of epiphyseal cartilage, right? So again, the word cartilage is contributing to this term enchondroma here. So epiphyseal cartilage, right? So very easy to identify on X-ray. Now we come to another entity, that is osteosarcoma, and this is again a very important topic from which we have questions almost every time. This is, we already discussed that it is metaphyseal, right? And around the knee joint, and whenever we say knee joint, the first one is lower end of femur, and the second one is upper end of tibia. Clear? So knee joint here. Now it is the second most common tumor, second most common primary malignant tumor of the bone after multiple myeloma. Now multiple myeloma is the most common primary malignant bony tumor, and osteosarcoma is the second most common. And if I remove the word primary from here, if I remove the word primary, then if I read the word statement like most common malignant tumor of bone, if I'm not using the word primary, of course it means the answer is secondaries. And secondaries is nothing except what you call metastasis. So it can come from carcinoma breast, it can come from carcinoma kidney or carcinoma prostate. The cancer cells, they can reach up to bones. This is again seen in 15 to 25 years of age, and patient can have pain, swelling. Now there are certain conditions which are pre-malignant. Now when I say pre-malignant, it means these conditions can later on convert into osteosarcoma. So later on convert into osteosarcoma. So these are the pre-malignant or predisposing conditions. One is of course the familial type of retinoblastoma, then radiotherapy, Paget's disease. Sometimes we can also include fibrous dysplasia and bony infarct. So these are all conditions which increases the risk of development of osteosarcoma later on. Now X-ray, I think pretty clear, two terms. One is of course the sunray appearance. Okay, so I think this is sunray, or at times you might have sunburst appearance. Second is the Codman's triangle, right? So the sunray or sunburst, this is because of calcification, which may be along the blood vessels or the Sharpie's fiber. So calcification along the blood vessels or Sharpie's fibers. Clear? This is one thing. Then Codman triangle, you can see here there is lifting of the periosteum, and as a result of this there is formation of a triangular area, and this triangle is known as the Codman's triangle. But please be noted that this is non-specific. Now when I use the word non-specific, it means it is not seen only in osteosarcoma, it can be seen in other conditions as well. So it is non-specific. Please remember this because it has been recently asked in ICT exam. Then there is new bone formation by the tumor cells, and there is bone destruction. So lysis means destruction. Clear? So there is destruction with moth-eaten appearance. Now this is a malignant tumor, and one of the problem with this condition is that it can metastasize. Clear? And usually it goes to lungs. So we can see a patient with pain swelling around the knee joint and presenting with hemoptysis, suggesting metastasis to lungs. And if we take a chest x-ray here, it will show cannonball shadows. Clear? So this is how we can check radiological evidence of metastasis. Now this is extremely radio resistant, so the prognosis is very poor. Osteosarcoma, very poor prognosis. Then we move on to Ewing's sarcoma, which is classified under small cell malignant tumor, right? So this is small cell malignant tumor, and just because on biopsy we see small size of cells. Now location, I think most of you can answer. This is diaphysis or the shaft, and this affects the children of second decade. Second decade means 10 to 20 years. So this is second decade. Again, patient will have pain, swelling around the knee joint specifically, or in the lower part of thigh. And X-ray, I think, although not very classically seen every time, but you can think something like this. So this is the onion peel appearance. So theoretically it's quite easy to say, but radiologically it is not seen every time. So onion peel appearance. But you please remember it from MCQ point of view. And this condition, since it affects the child of second decade, maybe around 15 years, and patient presents with pain swelling around the knee joint with high grade fever, so at times it looks like osteomyelitis. So this condition has to be differentiated from osteomyelitis, because chronic osteomyelitis usually affects the metaphysis or adjacent diaphysis also. So this becomes little confusing at times. So we have to differentiate osteomyelitis with Ewing's sarcoma, right? So Ewing's sarcoma, we already discussed, it affects the diaphysis of long bones and flat bones associated with 11 to 22 translocation, and this is also one aggressive condition. And when we say aggressive, it means it is very prone to cause metastasis. But the good thing is that it is a curable tumor because it is chemosensitive as well as radio sensitive, as compared to osteosarcoma, which is which is radio resistant, right? So this is one difference which you can clearly see here. This is radio resistant. Ewing sarcoma is radiosensitive, but we do chemotherapy because it is chemosensitive as well. Now moving to chondrosarcoma, we already discussed osteochondroma can rarely convert into a malignant counterpart, that is chondrosarcoma. It affects 30 to 60 years male, flat bones, long bones. It may be primary, means it is developing itself for the first time, or it may be secondary when it arises from osteochondroma. So when it is arising from osteochondroma, you will call it secondary. When this condition is developing itself for the very first time, that is known as primary. Again, pain and swelling are the usual complaints of tumors. Now the X-ray appearance or the gross appearance is pretty characteristic. So if we see a gross appearance, right? So if we see here, we can see a shiny mass within the medullary cavity. I think the word medullary cavity must be clear to everyone by now. Outside is the cortex. Okay, so this is the cortex. Fine. This is all cortex. This is also cortex. And inside is all medullary cavity. So within the medullary cavity, we will see this yellowish white glistening mass. So this is very characteristic of chondrosarcoma. So expansile, of course, it means it is expanding, right? So expansile, glistening means shining. And of course, the location you can see, it is present within the medullary cavity, right? So shiny mass within the medullary cavity. On X-ray, we can see within the medullary cavity, we can see a lot of dots of white dots, and these are actually calcifications, right? So these are all white dots suggest calcification, and since this calcification is occurring in this manner, dot dot dot, something like this, so this is known as mottled calcification. Clear? So this is known as mottled calcification. Is my voice okay? One student messaged like, voice not coming, sir. Anyone can confirm, is my voice clear? Please confirm. Is my voice clear? Shanwaz bhai. Okay, thank you. Confirmed. Okay, right. So we can continue. Huh? So mottled means all you can say slightly dot dot dot. Okay. So this is X-ray appearance. We can see mottled calcification within the tumor, especially involving the medullary cavity. And if we take a gross appearance, we can see within the medullary cavity, we can see shiny glistening mass. Clear? So this is chondrosarcoma. Then we move on to two cysts. One is the simple or unicameral bone cyst, and the another one is aneurysmal bone cyst. Now here, one difference is in terms of age. The simple or unicameral bone cyst affects younger patients less than 20 years of age, and this affects mainly, if you look here in the X-ray, this bone is humerus. Clear? So it is affecting upper end of humerus. Okay. Now another thing is that if you look here we can see the outline of physis. So this is all physis here. Okay. So this is physis, and below physis is all metaphysis. So one thing you can also answer that this condition is originating from which area? It is originating from metaphysis. Okay, so two things you can answer from this X-ray. In fact, upper end of humerus, metaphysis. Now what we can see on the X-ray, one thing is we can see blackishness in the tumor. So this is known as radiolucent or radiolucency. So right, so when I write the word lucent, the condition must appear black on X-ray. Okay, and this is in contact with the growth plate. So if you see here, the condition is extending somewhere till like this. So this is the extent of the condition. So it is in contact with the growth plate, right? So it is metaphyseal, radiolucent lesion, and almost in contact with the growth plate. Now what is very important to see here, if you take the entire extent of the growth plate, so this is the growth plate or physis, and if you take the entire extent of the tumor, it is shorter than the entire extent of growth plate. So maximum width of the tumor is less than the width of growth plate, right? So that you can see on the X-ray also. So the extent of tumor is less than the extent of growth plate, and this is very important for simple bone cyst diagnosis. And lower in the cavity of the cyst, you can see a fragment of the cortex which is broken and fallen down. So this is known as fallen fragment, or at times fallen leaf sign. So this is fallen fragment sign. So a part of cortex has broken and it is lying in the floor of the cyst. So this is simple bone cyst, and I think this is the simplest explanation for this entity. Now if you keep this much words in mind, you can take another entity for comparison. Now this is aneurysmal bone cyst, and I think most of you must be knowing what is an aneurysm of an, suppose this is aorta. Aneurysm means that aorta will become something like this. So this is aneurysm. Aneurysm means dilatation or expansion. So this is aneurysm. Now simply keeping this fact in mind, if we see here, the cyst is also expanding like this. So it is expanding like a aneurysm of an artery, and therefore we are using the word aneurysmal bone cyst, right? So the description becomes more clearer and it is easy to identify on X-ray. So this is aneurysmal bone cyst. Now this affects 10 to 40 years of patients, and commonly it is seen in tibia, although this one is again of humerus, unfortunately, because that will just might confuse you. So commonly it is in tibia, and again this region is metaphysis. Okay, so this is also same for simple bone cyst and aneurysmal bone cyst. But what is the main difference? That lies in terms of radiology, where we will see that there is an expansile blood filled lesions which is ballooning the bone. Now ballooning means just like this. This is known as ballooning. Okay, so this is ballooning the bone or expanding the bone, and at times it contains blood. And obviously you can say that the extent of the tumor is much more than the width of growth plate, but since it is seen in later part of the life, so the concept of growth plate is not being discussed here, and it can extend into the nearby tissues like soft tissue, and therefore it can give a wrong impression as if it is a malignant entity, but in reality it is just a simple cyst. So it is not a malignant tumor, but it can give a wrong impression as if it is a malignant tumor, right? So this is aneurysmal bone cyst. Then we move forward to multiple myeloma, which is the most common primary malignant, right? So this is the most common primary malignant bony tumor in the elderly age group, especially more than 40 to 50 years. And again, if I remove the word primary from here, the answer will become secondaries. This we have already discussed. So if we don't include the word primary in description, the answer will simply become secondaries. And what is secondaries? Secondaries is nothing except the metastasis to the bone. Now, if we do urine electrophoresis, we will find some proteins, and those are known as Benz-Jones proteins. So electrophoresis, now this is actually separation of proteins. So if we do it on urine, we can find Benz-Jones proteins. On microscopy, we will see Russell bodies, right? So this is a microscopic finding, right? And if we do electrophoresis of serum, so serum protein electrophoresis, we will find M spike, right? So this is M spike here, which is actually monoclonal immunoglobulin spike. And then there is one beta 2 microglobulin, which is an important prognostic indicator. Then RBCs may show Rowley formation on peripheral smear. Now Rowley means something like this, one above other, like a stack of coins, right? So this is Rowley formation. Then it is a, of course we said that it is a monoclonal plasma cell tumor. Now plasma cells are derived from B cells, right? So plasma cells, they form B cells, they form plasma cells. And yes, this is in bone marrow. Okay, we know that B cells, they mature in bone marrow, and therefore the most specific test is bone marrow biopsy. And plasma cells are the one which actually produces antibodies, right? So the immunoglobulins, they are produced by plasma cells. So B cells, plasma cell, immunoglobulin, and here we will find IgG or IgA. Now clinically, patient comes to us with low back pain, calcium levels are raised, so hypercalcemia. It can manifest as renal stones or renal failure, and there is formation of primary type of amyloidosis, and if you remember, AL protein, right? So this is primary amyloidosis. Calcium levels are increased, as we already said before, but the X-ray findings are pretty characteristic. You will see multiple black patches, right? So these are known as punched out lesions. So if you have a X-ray of the skull, and if you can see multiple black patches which are known as punched out osteolytic lesions, straight away you can jump to the diagnosis of multiple myeloma. So again, the word is osteolytic. So lytic is destruction. Clear? So because bone, it should appear white. If it is appearing black in terms of bony tumors, you will call it osteolytic, right? Then treatment can be by melphalan, steroids, or thalidomide. Then coming to some less important entities, one is Paget's disease, which is also known as osteitis deformans. Now deformans is taken from the word deformity, and osteitis is again bone, itis is inflammation. So there is deformity of bone as such. Now it can affect pelvis, tibia, or even skull here, and there is actually increased or uncoordinated high osteoblastic activity, and osteoclastic activity. Now, osteoblastic is bone formation, osteoclastic is bony resorption. So, this is formation and this is resorption. And this is extremely high and uncoordinated. So, what will happen as a result of this? The bony structure becomes changed. So, there is abnormal bony structure because of high uncoordinated osteoblastic and osteoclastic activity, and it can affect pelvis, tibia and skull. Now, why I'm specifically mentioning it over here? Because sometimes there is narrowing of the auditory canal and this results in deafness, right? So this involvement of skull, especially auditory foramen or auditory canal, it can result in hearing loss, that is deafness. Okay, so this is one clinical correlation. Now what we will see on x-ray, we can see cotton wool spots. Okay, and this is again sclerotic bone. Now when we use the word sclerotic, it will be more white, and more white means there is excess of calcium, which is again more indicative of more osteoblastic activity. So mosaic pattern or cotton wool spots. Then we can see chalk stick fractures in long bones. And here everything is normal. So there is normal calcium, there is normal phosphorus and normal parathormone. Only what we can see here is increased alkaline phosphatase. Right, so alkaline phosphatase is high. Now one of the thing which we have already discussed is it can predispose to development of osteosarcoma. So it is a pre-malignant condition for osteosarcoma, or at times it can convert into fibrosarcoma. Since the bony architecture is distorted, it can lead to pathological fractures or calcification with aortic stenosis and raised uric acid levels with urinary stones. So this is uric acid stones actually. Right, so this is Paget's disease or osteitis deformans, and you can use bisphosphonates like alendronate or risdronate, which inhibits osteoclast, and if these are inhibited, it will inhibit osteoclasis or osteoclastic activity, which is nothing except bony resorption, right? So we can use bisphosphonates. Okay, so this is cotton wool pattern, right? So if you see here, this is the cotton wool, right? So this is, and you can see sclerosis all white, right? So this is all white. Then we come to fibrous cortical defect. Now I think you must be knowing what is cortex. So suppose if this is a long bone, this outer part is cortex and in the middle is all medullary cavity. Okay, so this is the medullary cavity and this outer part is cortex. Clear? So this is all cortex. So when I am saying fibrous cortical defect, so it means we are discussing some condition which is involving the cortex only. So here if you see in the x-ray, there is a fibrous cortical defect. So it is also known as non-ossifying fibroma, and it is an accidental finding. You did x-ray for something else and then you noticed, oh, there is a fibrous cortical defect as well, and it is again involving the metaphyseal area, and we can see a well-defined lobulated lesion which is eccentrically in metaphysis. Okay, so this is fibrous cortical defect. So again, you can see here the word eccentric, but this is not epiphysis of giant cell tumor. This is metaphysis of fibrous cortical defect. Okay. So this is fibrous cortical defect. Then coming to fibrous dysplasia, this affects 20 to 30 years age, especially proximal femur, right? So if you see proximal, this is proximal femur, this is middle, and this is distal. So it is affecting the proximal femur, and here you can see there is complete derangement of the architecture of the proximal femur, something like this. So it is also involving the metaphysis, and the characteristic thing, or with the point which you need to remember for exam point of view, that is Shepherd's crook deformity, right? So Shepherd's crook deformity, you can see curvature something like this. So this is the Shepherd's crook deformity of proximal femur, and then there can be ground glass appearance with trabeculations. Leave that. So this is fibrous dysplasia. Now coming to one more condition, that is chondromyxoid fibroma. Again, not that important. It can affect 10 to 30 years of old, especially involving proximal tibia, right? So this is chondromyxoid fibroma, and there is no calcification as such within the tumor. So chondromyxoid fibroma. Now moving forward to hemangioma. Again, the word hemangioma means something related to vessels. This is a benign lesion, but you just need to remember about its radiological features. Now if you are taking a transverse section, means if you are cutting a vertebra, so this is transverse section, and what you can see here, you will see multiple dots, and these are known as actually the polka dot pattern, right? So you will see multiple, if you can see multiple black dots here. And if you take a lateral view, right, so this is a lateral view. In lateral view, you will see multiple vertical lines, something like this, right? Here you are seeing black, some spots like this. So this is polka dot. Okay. And in lateral view, you will see transverse lines, which actually looks like as if it is a bar of a prison. So that is known as jail house or linear striations or corduroy appearance, right? So this is, it just looks like a bar of a prison. So jailhouse appearance. Then the last topic of this session is metastasis to bone, and metastasis is also known as secondaries. It means the primaries are, it may be in, in breast, the primary tumor. So the primary tumor is in, you say, breast. Primary tumor can be anywhere in the body. So in females it can be in breast, it can be in kidney, in males it can be in prostate. So from here the tumor cells, they travel all the way to bones, and then there they affect the bones. So that is secondaries. Now in males, majority of the cancerous cells are coming from prostate. In females, the majority of cancerous cells are coming from breast, right? And majority of the tumor cells, they finally land into the thoracic or the dorsal vertebra. So majority of the metastasis is reaching up to this place. Now what you can see here, if you look at this MRI, now this is intervertebral disc, right? This is vertebral body. Now what we can see here, this is the osteolytic, this black is all the area, the bone is damaged here. So this is the osteolytic area, and this is because of secondaries. Now what we need to look here, that intervertebral disc space is maintained, it is not reduced. So this is very important here, because at times we can have this kind of MRI in tuberculosis as well, but in TB the intervertebral disc is also reduced, right? So in TB we will see osteolysis plus reduction in disc space. Clear? So this is how we differentiate whether a given MRI is of tuberculosis spine or whether it is because of secondaries. So in secondaries, the intervertebral disc space is maintained. Now, in majority of the tumors, the tumor cells will go and they will destroy the bone. Right? So it can be from kidney, it can be from thyroid, but there is only one tumor in which the cancer cells will reach to the bone and there they will form new bone. And when there is formation of new bone, we call it sclerosis. Right? So here it is osteolytic, here it is osteoblastic or osteosclerotic, and this entity is carcinoma prostate. Fine. So this is carcinoma prostate. Just remember this term because of this unique feature. It has been asked many number of times, right? So this is very important here. And in X-rays of spine, we can see one important sign, and that is winking owl sign, which is seen because of destruction of pedicle on one side. Right? So because usually what happens when we take a AP view, now this is on AP view, right? So the pedicles are seen something like this. This is normal. But what happens in metastasis, one of the pedicle will be here and another will be damaged like this. So this is the winking owl sign. Clear? So please remember this much for oncology or orthopedic oncology, and I think question should not go beyond this much matter. So I think you must have enjoyed the session. So see you later on with another video, and thanks for joining me. God bless. Keep on studying. Bye bye.